Tier What? Understanding what specialty tier could mean for you. Today's presenters are Emily Shetty and Wendy Owens. Emily Shetty is the Senior Director of Federal Legislative Affairs with the Leukemia and Lymphoma Society, and Wendy Owens is the Principal Investigator and Project Manager of Choice Project, Hemophilia Federation of America. Today we are going to go through a journey of what tiering could mean for you. Just a few housekeeping issues. If you have a question, you may either type the question or raise your hand, and at the end of the webinar we will unmute you and you will be able to ask your questions. You should see the opportunity to write your question in the right hand corner of your screen. All questions will be answered, and we hope that everyone is very engaged in the process. This webinar will also be available on the HFA YouTube channel, so you will be able to view it later, and there will also be an opportunity for you to receive additional materials following the webinar. I would like to first read a few questions regarding the specialty tier, but before I go into that, I want to read the bios of our two awesome presenters today. The first bio is of Emily Shetty. As I said, she is the Senior Director of Federal Legislative Affairs for the Leukemia and Lymphoma Society. Emily manages the Federal Legislative Affairs portfolio of LLS, focusing on ensuring sustainable access for patients to affordable, coordinated, quality health care. She joined LLS in July of 2012 after having served the Legislative Director for Representative Adolphus Ed Towns from Brooklyn, New York. Emily recently received the Every Life Foundation's Rare Voice Award in recognition of her work on the passage of enhanced accelerated approval provisions of the Food and Drug Administration Safety and Innovation Act of 2012. Emily earned her JD from Catholic University and received a BA in Mathematics and Certificate in Markets and Management from Duke University. Wendy Owens is the Principal Investigator, Project Manager, Choice Project for the Hemophilia Federation of America, and prior to joining HFA as the Principal Investigator and Project Manager for the Choice Project, Wendy was the Executive Coordinator for New England Coalition for Affordable Prescription Drugs, or NECAPD for short. Her initial experience with the hemophilia community was as the Advocacy Coordinator for the New England Hemophilia Association. Wendy began her career in the private sector, starting and running several companies, including an advanced composite materials engineering firm with technology patented around the world. For the past 11 years, Wendy has been an advisor to the U.S. Secretary of Commerce and U.S. Trade Representative on Information and Communications Technologies, Services, and Electronic Commerce as a member of an Industry Trade Advisory Committee, or ITAC 8. Wendy lives in the greater Seattle area with her family. Today, we hope that you are encouraged, inspired, and informed. Please continue to write your questions as the webinar goes forward, and we will get to those questions at the end of the webinar. Let us begin.
Good afternoon, everyone. My name is Emily, and thank you, Janelle, for that very kind introduction. Thank you all for participating in today's webinar on specialty tiers and the impact they have on patients with blood disorders and blood cancer. I'm so pleased to join our wonderful colleagues at the Hemophilia Federation of America for what I'm sure will be an informative discussion on this increasingly important issue. Broadly speaking, patients are adversely impacted by specialty tiers. The first question that many of you may want me to address is, what are they? What are these specialty tiers? Specialty tiers are a tool employed by insurance plans to manage risk within their insured patient population by shifting costs from the plan onto the patients. Every insurance plan decides how to structure their prescription drug benefits and what therapies to cover. The key unifying feature of specialty tiers is that for those that charge co-insurance, the plan is shifting a large percentage of the cost of the therapy onto patients. In addition to the premiums that patients pay each month for benefits, each time that a patient fills a prescription at the pharmacy counter, they are charged between 25 to 50% of the drug's retail cost, in lieu of a set budgetable copay. The definition of a specialty tier varies in Medicare versus the commercial market. In the Medicare prescription drug plan, known as Part D, all covered drugs that patients receive from a pharmacy that cost over $600 are classified as, quote, specialty drugs. In the commercial market, there is great variation per plan. In 2012, 14% of plans have specialty tier, but in this year, in 2013, 25% did. So as you can see, this is a practice that is being increasingly adopted by insurance plans. It's important to remember that this practice preceded recent insurance market changes and was left unaddressed by those changes, but more on that later. Again, broadly speaking, patients that are adversely impacted by specialty tiers have anecdotally shared with LLS, and I'm sure with the Hemophilia Federation of America, that these are the four impact areas that they are facing. Specialty tiers can pose a huge access barrier to patients that need life-saving therapy. In fact, we know that data shows us that once a prescription exceeds $100, patients have difficulty accessing that therapy, which leads to more people not filling their scripts. In both the blood cancer community and the hemophilia community, this leads to an increase in hospitalization rates and hundreds of millions of dollars in avoidable costs to the healthcare system. On an individual level, our patients report that when they do not have access to necessary care, their productivity declines and they experience significant challenges to their quality of life. I'll turn the floor over to Wendy now for her portion of the presentation.
Okay, thank you very much, Emily, and thank you, Janelle, for that lovely introduction. Again, I'm Wendy Owens with HFA. I just wanted to put into context for you the cost of specialty tiers for people who are in the private sector in terms of getting either from the marketplace, their insurance, or from private sector marketplace. So we know now that a change has been made with the ACA that your annual out-of-pocket cost for health care for an individual is $6,350, and for a family, $12,700. But what if your coinsurance payment for a specialty tier drug was $300 a month? So if you're an individual and you have a specialty tier drug that you use, in that first month of the year, let's just say we're starting in January, your coinsurance payment for that specialty tier drug would be $3,000 for that month, $3,000 for February, and then another $350 in March. For most people, like Emily said, this is really just simply not sustainable. And it would mean that you would have a very tough Christmas season or holiday season, certainly, because you'd be saving for those first 2 months of the year every year and for you in order to be able to pay for your medication. So you can see how specialty tiers, if they're used for your medication, if your medication does go on the tier under your pharmaceutical plan, they can cost you a lot of money. Now, for a family, it will also, here's another chart. If Janelle, are you clicking forward? Drive control. Emily, can someone click the slide, please?
I'll turn over the control to you.
Okay. Nope, I can't show my screen. You got me showing my screen. Let's see. Sorry, guys. Okay, so you can see this is the individual. And next, for a family, you can see how truly detrimental it could be for a family to have to pay out-of-pocket costs for specialty tier drugs. That's $3,000 4 months in a row, plus your last $700 in May. That certainly could be devastating. And I just wanted to bring this up early in this webinar so that you could see the numbers of how specialty tiers can impact both individuals and families. Also, I wanted to show you just quickly a list of specialty tier drugs. These are the top 50 specialty tier drugs. And the as Emily said, most drugs are over $600, and Medicare Part D are in specialty tiers. But you can see now that these are the drugs that are being moved into specialty tiers for number 1, 99.93% of the time, and number 50, 90.66% of the time. So you're definitely, if any of these are your drugs, it's likely that your drug will be on a specialty tier. I want to just put a caveat in there for our hemophilia community, specifically that most hemophilia factor is now still covered under major medical. But there is a strong trend now where insurance companies are moving factor from major medical coverage to pharmaceutical coverage and then moving the factor into specialty tiers. So something that's why we really need to be aware of it in the hemophilia community.
Okay, so we're on to the specialty tiers in the commercial market area. This graph is a visual depiction of a drug formulary in the commercial plan that uses specialty tiers. Commercial plans are those that are employer-sponsored or individual that are basically all non-Medicare, non-Medicaid plans. These are your Aetnas, your Blue Cross Blue Shields, etc. Generic drugs make up the bulk of therapies on most formularies. In fact, about 80% of therapies are generic, and often insurance plans incentivize their use by charging low copays. Preferred and non-preferred brand drugs make up comparatively a lower number of therapies on a formulary, and plans disincentivize their use by increasing the cost per tier. Specialty therapies make up the smallest number of drugs, but for these therapies, plans charge a coinsurance in lieu of a set dollar copay amount. In this sample plan, I've shown a 30% coinsurance, which is not uncommon for plans that we've seen across the commercial market. For blood cancer patients taking orally administered therapies like Gleevee, this can amount to 30% of around $10,000 each month, or a $3,000 a month out-of-pocket expense for one drug alone. On our next slide, we examine what specialty tiers look like in Medicare Part D. As I mentioned earlier, Medicare defines specialty tiers differently than the commercial market. By law, all drugs that cost over $600 are placed on a specialty tier, but not all plans charge coinsurance for them. However, most of them do. I believe in this year's open enrollment, between 85 to 90% of Medicare Part D plans are currently using coinsurance on specialty tier therapies. This slide shows a sample plan, the Express Scripts Medicare PDP plan offered where I live in Maryland. In this plan, after the patient satisfies their $310 deductible, they pay between $2 to $7 for every generic and brand drug on their formulary, and a coinsurance of between 25 to 50% for specialty therapies while they're in the coverage phase of the plan. As you can see, a patient taking the blood cancer therapy Gleevee blows through all levels of Part D, the deductible, the coverage phase, coverage gap, and enters catastrophic coverage in their first month of taking this therapy. Thereafter, they pay 5% of the cost, around $356 every month through the end of the year. In January of the following year, they'll do it all over again. If in lieu of coinsurance, the plan charged a smaller copay, say $100, the patient would stay in the red coverage phase from January to December and pay a total out-of-pocket cost for the entire year of $1,510. That math works out to $100 each month plus $310 for their deductible in January. By comparison, under current law, this patient is paying over $6,000 for their one cancer therapy over the course of the calendar year. For this next slide, I turn the floor over to Wendy to present.
Sure, thank you. So, as Emily mentioned, things have changed, obviously, in the insurance landscape, and we've been hearing about that lots lately. And certainly the Affordable Care Act is making lives better because it is providing coverage for more people, broadening the way that we receive our care and improving our care. We know that we have an individual mandate now. People are required to have insurance, except for some exempt classes. Our coverage for our adults, young adults to age 26 with their parents. The prohibition on pre-existing conditions, which is just fabulous. It's kids right now, but adults beginning January 1 of next year. Elimination of lifetime caps. We have free prevention and wellness service benefits, and we also have our essential health benefits. This all leads to and has come from a new attitude in healthcare. And that attitude is, if you guys could click that slide, please. Patient-centeredness. It's kind of a funny word, the centeredness, but that's now the focus. The focus that the ACA brings to this insurance landscape is patient-centeredness. So there's three things now that insurers are going to focus on, and that is cost, patient satisfaction, and health outcomes. So now insurers who pay for the care that you receive, they're going to say, all right, doctors and hospitals and other types of providers, we want you to have the lowest cost, the highest patient satisfaction, and the best health outcomes. And that's really how they're going to start judging healthcare, which makes healthcare more of a meritocracy, really puts health businesses for how we have to serve our patients, and actually how we serve our community and how businesses then serve their customers. So very much more customer-oriented, focused on the patient. So you're going to see more of that, but that also means that it may come with a price tag. And so as the ACA is implemented, as we move forward, there are likely to be other changes in insurance to try and balance out the cost of providing everyone care. So please do keep that in mind, and note that specialty tiers this issue was not resolved by the ACA. So under the new laws, the specialty tiers, they have no place. We have to legislate, we have to find a way to make sure that specialty tiers do not cause the catastrophic damage that they could cause based on what Emily's shown you in terms of costs for Medicare Part D patients, and then what I showed you for the private sector. These things can just be terribly detrimental for families, for individuals, and what's the use of all these new great things in our law if we're still going to have holes where people who desperately need life-saving medications, life-changing medications, things that keep them healthy and productive, if they can't afford it. So we need to keep that in mind as we look at the specialty tiers issue. Next slide. So when I worked on 5 pieces of specialty tier legislation at the state level in New England, we passed three different pieces, Vermont, Maine, and New Hampshire. New Hampshire was integrated into another bill. And so, but when I was working on these bills and we were talking, we were telling the senators and the representatives of at the state level, why specialty tiers were something that could be very detrimental to people in their communities. Why specialty tiers should be either no specialty tiers allowed, or if they are allowed, to somehow set some type of limit in the use of specialty tiers. But I wanted to share with you, and those people who are considering putting forth legislation in their state, or people who are considering talking to legislators in their state or even at the federal level, these are the things that the opposition said to us and to the state legislators. So what they're trying to do is say tiers to let patients know that drugs are more expensive and which ones are less expensive. And their line of argument was preferred drugs are the preferred drugs. We prefer these drugs anyways because they are less expensive for us. I'm not sure how tiering is a way of sharing the savings with the patient, but that is another direct quote from a letter of opposition to our specialty tier bills. Tiering is an incentive for patients to make better use of resources. I'm not sure how that's really works out either. But these are the kinds of arguments that you will face. Tiering a tool to manage pharmaceutical spending helps patients know the true cost of health care. If they were prohibited, the manufacturers would charge higher and higher prices for branded medication. One more click, please, on the slide. And the opposition goes on. And this is not an exhaustive list of the opposition. So tiering is for lowering the price of brand name drugs, discounting drugs, precluding specialty tier would accelerate the shift of healthcare costs to insured families and individuals. What they were trying to say is that if there isn't any tiering and we, as a patient, you're only paying for example, $150 out of pocket a month for your medication, then your employer will have to increase your premium rates in order to cover the cost of the drug and the cost of the insurance overall. So there were lots of arguments in saying that the employer would certainly have to increase your insurance premium rates if specialty tiers were not allowed. And finally, the benefit providers should be able to create their own health benefits based on their own needs and values. So this is in opposition to that patient-centeredness that I just talked about. Next slide when you guys have a second. There we go. So what we did, New York was the first state to have specialty tier legislation. And they went in and they said, this is going to be a preemptive strike. We see the specialty tiers being coming. We see that Medicaid Part D is where it started. We see it now moving into the private sector. We got to get rid of this stuff. This is an absolute. So for New York, they got rid of specialty tiers. There are no specialty tiers allowed in New York. So they actually passed legislation in 2010, completely banned the use. And then we went in Vermont and Maine and Delaware, and I worked on the Vermont and Maine legislation, but not the Delaware legislation, but was aware of it. We said that there's a cap, there's a limit on specialty tiers. And so there's out-of-pocket costs actually are limited. And in both Vermont and Maine, the language includes out-of-pocket cost limitations specifically for prescription drugs. And then it also says, and if this is in any way in opposition to what the ACA says, then we accept what the ACA says. But we made sure that the laws would work well together. There are other states that are looking to pass legislation in opposition to specialty tiers. And what we find generally in this whole advocacy policy world is where the states go, so does the federal government. So the federal government, there has been legislation introduced at the federal level that would limit your out-of-pocket costs for specialty tier medication. But here are a few other states in which either legislation is pending or they had put forth legislation. And the best legislation we found, the best language for legislation, has not been to set a dollar amount. For example, it has not been to say you're absolutely precluded from charging more than $150 for specialty tiers. And that doesn't work because in any business model, you need to have some flexibility with your price. So we've learned through the process of these states putting forth legislation, what really works, what legislators and businesses can agree on. So we're now improving that legislation, and I think we have a really nice bill at the federal level now. So that's where we are. And I'd be happy to answer questions at the end about specific state legislation and legislation in your state as well.
Thanks, Wendy. So there are two bills that HFA and LLS are working on to address specialty tiers in the commercial and Medicare markets. H.R. 460, the Patients Access to Treatments Act, is a bipartisan bill currently in the House of Representatives. This bill solely addresses specialty tiers in the commercial market by, in effect, prohibiting the use of coinsurance. Both HFA and LLS belong to a large coalition of patient and provider groups that have recently funded a study by a very respected independent healthcare consulting firm, Advocacy. This study found that the bill, if enacted as currently written, could potentially have a $3 per year impact on premiums, or a 25-cent per month impact, only on the plans that currently use specialty tiers. We view this as a huge win-win for patients and the healthcare system as a whole. On the Medicare side, we are working together on a bipartisan bicameral bill, the Part D Beneficiary Appeals Fairness Act. This bill addresses specialty tiers by allowing patients to appeal the cost of a therapy that is placed on a specialty tier when no alternate lower-cost drug is available. This process currently exists for therapies moving from non-preferred brand to preferred but does not exist for therapies that are on a specialty tier. Visually, this is what the patient access to treatment looks like. In a sample plan that charges 50% for a specialty tier currently, that plan would go from a 4-tier structure to a 3-tier structure, where specialty and brand drugs would result in a $30 copay. Just by way of example, for patients who are taking Gleevee, that means going from a $5,000 monthly out-of-pocket expense to $30. Clearly much more accessible. The Part D Beneficiary Appeals Act moves us from a system that currently allows patients to appeal the placement of a drug on a non-preferred tier when there's no medically equivalent lower price alternative to allowing appeals at all levels. It's important to emphasize that this would not apply for all drugs and is not an automatic process. It is very narrowly drawn to only apply to therapies that do not have a medically equivalent lower price alternative, and the onus is on the patient to apply for the appeal. Until the appeal is granted, patients will likely have to pay the upfront cost to fill the script, but thereafter the lower price would be honored. It's a common sense effort that will increase access for all of our patients. Wendy?
Thanks, Emily. So what I want to talk about now is, having worked on the specialty tier drugs in those 5 states, the most important thing that we had on our side was not the facts, was not our arguments against the opposition. It was patients. We would not have had the legislation passed if it weren't for patients. In Maine, we had a Republican committee chair who absolutely was opposed on one day to the bill, and then we had our patients come in and tell their stories, and the next day he completely flipped and he said he was all for it and let's pass this bill. And the reason is that he heard from patients. Patients said, look, if this happens and I have to pay $30,000, and this is prior to the ACA being enacted, so there were no out-of-pocket limits. If I have to pay $30,000 a year or a month or however it is, or let's say a year for my medication for my child who has hemophilia, I can't do that. It is not possible. My child, this little boy, will suffer terribly, have permanent joint damage, and if has any other bleeds in any other locations that could cause death, it may die. So he was so moved by, we had hemophilia patients, we had MS patients, and we had LLS patients at the hearing, that he just said, no, absolutely not. I'm not listening to the opposition any longer. We can't do this to people. And even though it was preempted, even though we were preempting the actual addition of specialty tiers to formularies in Maine, the legislators saw that if they were allowed to use these specialty tiers and then it had to be legislated away, wow, that could take a long time and people can suffer terribly. So patient stories, that's what makes the difference. The legislators work for you. They want to hear from you as patients. They can hear from lobbyists and they can hear from us, but there's nothing like hearing from the patients. You give the legislation context and meaning. By saying, look, this affects me in this way, and this will undermine my quality of life, and this will cause me to not be able to be productive in my life and productive in my family and contribute, then they say, oh, now I get it, because I have someone, I have a name, I have a face, I have that person to connect to this legislation, and why it is so important and vital that we either pass a piece of legislation or not pass a piece of legislation. So I can go on for days, and I'm sure Emily can as well, in terms of best practices for advocacy, but I really just want to focus on two things. As I was saying before, there's power in people. Really, if you join forces together, if you're one to undertake legislative effort to have a bill introduced in your state legislature that either bans specialty tiers or somehow puts a cap or does just what the 2 pieces of federal legislation are talking about that Emily discussed, then you need to reach out for help for people who've actually done this and been successful. and they will help you. That's the great thing. And you need to find a legislative champion that will champion this cause. So there's some steps, and we can, certainly I know LLS can help their patients, and we can help our patients if you want to go forward with this. But I just want to focus on that. And the second thing I want to focus on, which falls right in line with power and people, is communication. We use the media a lot in the 2 states or 3 states where we had legislation passed. We used it in the other 2 states as well, but the legislation just it wasn't timely for those in those 2 states. But we were on NPR, we were in newspapers, we were on the television, and we did that because we had patient stories, and those patients, again, going back to them, they were the ones that made a difference. Their stories really touched people. You want to use calls, you want to use emails, you want to use meetings with your legislative members, legislature and your staff members, and you really want to have clear, concise message, and you got to have numbers. They love numbers. 2 things, people and numbers, and those are the 2 things that you really need to be able to communicate with are the people that are going to be impacted by the legislation and the numbers that will affect their lives, just like we were talking about earlier in the earlier slides. And again, I know both of our organizations can certainly help further with best practices, and HSA, we have a whole handbook and tools and so forth for it. But I just wanted to focus on these 2 things.
Thank you, Wendy. So at this point, we're going to begin our question and answer session. Apologies again for our earlier technical difficulties, and we thank you all for bearing with us until this point. So we look forward to answering any questions that you may have. And Janelle, do you want to go over again the process by which people can ask?
Absolutely. Please look on the right-hand corner of your screen in the panel. There should be an opportunity for you to type your question. You may also raise your hand, and I will unmute you, and you will be able to ask your question directly. Please feel free to ask great questions of these very knowledgeable ladies. Okay, I see the first question is, my home care organization used to pay for my needles, syringes, and other ancillary supplies. They stopped doing that because of Obamacare. Does this mean I'm now in a tiered insurance plan? Which one of you would like to tackle that one?
I think given that this is a hemophilia patient who's making this request, Wendy, would you like to take this question?
Yeah, sure, I'd be happy to. So the answer is no. You're not in a specialty tier plan that we can tell from what you've just told us. So the specialty tier plan would mean, and you would likely be informed, that if your factor was under major medical, that it would now be moved to your pharmaceutical plan, and that information would have to be provided to you. So because you no longer receive the your needles and so forth, it may be that, and I'm not sure it's because of Obamacare as well. There's a lot to that question that we're not sure of. I would go ahead and ask your home care company specifically why you're not being supplied with that, what you need. You should be supplied with that. So go ahead and contact them and ask them why and how you can make sure that you do receive what you need. You should be receiving that with your factor.
All right, great. Emily, would you like to add anything?
Yeah, I just want to add that I think it's important to remember that this practice preceded the changes in the Affordable Care Act or Obamacare, and it was unaddressed for the most part by the Affordable Care Act. But the key way to know whether you have a plan that has a specialty tier is when you go to the pharmacy counter and you have been charged a percentage of the cost of the therapy in lieu of a budgetable dollar amount. That's the key identifying factor. And you typically know this because instead of paying maybe $50 every time you get a prescription, you're paying $2,000 or a very high amount. So it's I think that's the key way to know whether you have a plan with a specialty tier.
Okay, great.
In hemophilia,
There's another question asking whether or not the slides will be available. Absolutely. These slides will be available on the HFA website.
And we will work to get them available as well on LLS's website.
So you will have ample opportunity to go over, go over the information and review it again. There is another question. Does tiering affect, there are a lot of hemophilia people on the line, also LLS, get your questions in as well. Does tiering affect the hemophilia community since we'll meet the out-of-pocket maximum of $6,350 in the first month? Wendy, do you want to take a stab at that one?
Sure. Well, if your factor is moved from major medical to your pharmaceutical formulary, and they move factor onto a specialty tier, then yes, you will be affected by specialty tiers. So when Emily was talking about for hemophilia, of course, we're not talking about over-the-counter. We don't go to the pharmacy. The specialty pharmacy will deliver factor, and you would see on your bill an increased charge, and that's how you could likely tell that you've been moved from major medical to pharmaceutical. But we've had, just by experience, anecdotal, people have been told in advance that their factor is being moved from major medical to the pharmaceutical before it happens. Not that they have a choice, but it happens, at least they're informed. Am I answering the full question, Janelle?
Absolutely. Emily, would you like to add anything?
Sure, yeah. So the question was, am I affected given that we now have these out-of-pocket caps on our plans? And for both communities, I think that the key issue is that, yes, over the course of the year, you will have now this cap of $6,350 on your drug out-of-pocket costs. But the real challenge is that, in January, people are often coming right off the heels of, spending money for the holidays, buying presents for their family members and their friends, and often January is a really difficult month for many people financially. So to have to pay $3,000, $5,000 in January right after the holidays can be a really big burden. So yes, the out-of-pocket maximum is helpful, but it really applies for the entire year, and if you're paying all of it up front in January, that can be a big challenge.
Okay, I have a question for both of you. Seems like someone has been doing their research. The question is, what can we do in Texas to get the $150 out-of-pocket maximum for prescriptions like they did in Delaware?
So this is a really great question, given my focus is mostly on federal legislative affairs, I'd love to give Wendy the opportunity to answer that question on how to mobilize efforts on the state level.
Yeah, I'd be happy to address that, and it's really a matter of what legislation and the language of legislation would be applicable within your state. So Delaware was able to get the $150 maximum out of pocket, and I'm not sure that that's perpetually $150. It may increase with inflation, but that's something that we would have to check on. But again, as I mentioned, other states have not found great success at all in setting an absolute out-of-pocket maximum in the law that would say no more money than this. A better practice, a better approach may be saying, just like the federal legislation is saying that Emily presented, that you really, specialty tier costs cannot be any more than the non-preferred drug cost. You can't go beyond what your non-preferred drug cost expense could be. And that's probably a better, more likely to pass result, but it really depends on your legislative atmosphere, the opposition that you're feeling in the state, and what's going on. So what you need to do, if that's something that you want to pursue at the state level, we can certainly talk about that more online, but you would have to begin with finding some language and talking and finding probably a legislative champion that you could work with who would give you some idea about what would be more likely to pass than in the legislature, give you some sort of who else you might want to get to be another champion on your bill, and that's kind of how you would have to start, is finding that person that you can talk with initially before, and then finding if they would be willing to introduce legislation and what type.
Great, Wendy. So our next question is, are plans in Medicare or the commercial plans charging co-insurance for anything other than drugs? Emily, want to take a
Sure. Yeah, I'd be happy to start the answer on that. So in Medicare, many of our patients who are enrolled in Part B, and which is just the general Medicare healthcare plan, for their doctor's visits, they're paying currently, I believe, a 20% coinsurance for any costs associated with visiting their physician's office. We've also seen coinsurance for specialty visits, so visiting an oncologist or a hematologist is often charged at a coinsurance of a certain percentage. What many patients do in Part B is they purchase Medigap policy to help cover the cost or help lower the cost of their plan. And they pay premiums every month towards that plan to have an additional set of benefits above and beyond what the basic Medicare plan offers. On the commercial side, there were a couple. We've seen that there could be examples on the state level in some of the marketplaces that have been rolled out as part of the Affordable Care Act of coinsurance being charged outside of the drug plan. So this is a practice that is increasingly being adopted, and the fear we have is that this will continue to shift the costs from the insurance plan onto patients.
All right, great. Wendy, is there anything you would like to add?
Sorry, Janelle, I was offline and missed that question. So.
Problem. I will repeat the question. The question is, are plans in Medicare or the commercial plans charging coinsurance for anything other than drugs?
Yeah, I think Emily covered that just fine. Yeah.
The next question is, we're having a lot of questions today. I love the engagement. This is great. Do out-of-pocket maximums apply to all insurance plans? Emily, would you like to chime in on that, or Wendy, would you like to give it? Okay, so Wendy, we're going to push that one over to you. Do out-of-pocket maximum apply to all insurance plans?
So except for exempt plans, so grandfathered plans that are currently ones that were grandfathered in under the ACA, and also plans in out-of-pocket maximums also for plans that use two providers right now. So you may have one provider, insurance provider for medical coverage, and you may have another insurance provider for pharmaceutical coverage. They do not, the out-of-pockets do not apply to them until 2015. So that is one difference. And Emily, I imagine that I'm missing something. So,
no, Wendy, I think you covered it really well.
Okay.
All right, great. So that brings us, we have one last question. We still have about 9 more minutes, so if there's a burning question that you have not been able to ask just yet, please type that over or raise your hand and we will call upon you. The final question that I have here is, what should be the next steps for engaging with our advocacy efforts? So actually, if you both could address that individually, that would be great. So for hemophilia, what should the next steps be for persons to engage in advocacy efforts? And for leukemia, lymphoma, what should be the next steps for folks to engage in advocacy efforts?
So I'll go ahead and start. This is Emily with the Leukemia and Lymphoma Society. For our patients who are on the phone now or listen to this recording later on, many of you know this, but we have a really wonderful grassroots mobilizing effort that we are organizing through primarily our website. So if you visit www.lls.org/advocacy, you can find our position papers on the federal and state issues that we're working on regulatory issues that we're working on, and you can sign up for our advocacy database so we can contact you, let you know when there are exciting campaigns that we're working on that you can plug into. We also have 56 chapters across the country. Each are mobilizing locally our advocacy and grassroots efforts. So you can contact our local chapters that are closest to where you live. If you're not already plugged in with them, they're a wonderful resource on the ground, and you can always call our office if you have further questions. And our contact information is on lls.org.
All right, great. Wendy, would you like to inform the audience as to how persons involved with the hemophilia community can get involved in advocacy efforts?
Sure. Pretty much the same thing. We on our HFA site, hemophiliafed.org, we have a substantial body of information on the issues that patients with hemophilia face and how we're looking at those from an advocacy perspective. We certainly would appreciate any support of our federal efforts. We have Hill Days that we're going to be running, where we bring patients into Washington, D.C. to speak with their specific state legislators at the federal level in Congress for example, on the RH460 that we're looking at with specialty tiers. We have chapters who are very involved in advocacy efforts, who we also as a national organization support directly to help them achieve what they want to achieve at the state level with legislative issues or regulatory issues that they're facing there. So we're basically here to help, very much like LLS. What do you need from us? Just let us know and reach out and let us know then how you might help us and help support the efforts that we're making. So again, hemophilia.org/advocacy. You can reach us there or email us. Or give us a call. The contact information is on the website, and we look forward to working with you.
All right, great. I believe that all of the audience members, as well as myself, are truly grateful for your presentation today. We have been enlightened, and we look forward to contacting each of you at the respective websites that are on the screen. This entire presentation will be available on the Hemophilia Federation's YouTube channel, and I would also like you all to know that those in attendance will receive supplemental documents in terms of tiering, and so look forward to that in your email. And you can also join us on the week of December 16th. It's going to be, I believe, December 16th for the next advocacy webinar, What to Expect from the ACA in 2014. So be on the lookout for that. Thank you all for joining us today, and have a great remainder of your day.